Hi, and welcome to Understanding EEG, Episode 2, Normal Awake and Asleep EEG in Adults. I'm Jake McKay, board-certified neurologist and neurophysiologist. Welcome back to Understanding EEG. Thanks for sticking with me. This is an exciting episode because we will focus on normal awake and asleep EEG. Understanding normal EEG is absolutely essential to mastering the art of EEG interpretation. Without a thorough understanding of normal EEG, you may be fooled by normal variants of a dynamic brain. Please, once again, let me know if you have any questions, and I'll be happy to answer them by way of email or WhatsApp. Thanks again for watching, and let's get to it. As you might have guessed from the title of this lecture will focus on normal EEG, specifically that which occurs during wakefulness and during sleep. Part 1 will focus on the normal awake EEG. We will present the physiologic generators of artifact which are commonly seen during the awake EEG. Furthermore, we will discuss the commonly seen EEG patterns which you are likely to encounter during a standard EEG recording. Normal asleep EEG, in part 2, will focus on the features which will help you identify stages of sleep of the patient, as well as what is the underlying purpose or cause of several of these generators. Before we begin in earnest, let's discuss Principle 3, Know Your Normal. While you learn EEG, take the time to identify normal features of EEG in each record you encounter. Don't just look for abnormalities. Familiarity with normal EEG will help prevent the overcalling of epileptiform discharges. When we begin to discuss the normal awake record, it's important to consider the dipole of the eye. The eyeballs are actually natural dipoles. The cornea is more positively charged than the retina. This leads to artifact with eye movements. In particular, when you have vertical eye movement, as is seen with eye closure due to Bell's phenomenon, this makes the frontal leads in the electrodes more positive, leading to a downward or a positive deflection in the anterior-most leads. Here we see these downward deflections, which start with the highest amplitude in the frontal electrodes. This is called vertical eye blink artifact. And notice that because the eyeball dipole is actually outside the cerebrally generated field, that the first electrodes have a much higher amplitude than the subsequent electrodes, and by the time you're in the occipital region, you don't see the waveform at all. This is common to vertical eye blink artifact. Here's another example, and in this example, you see there are several vertical eye blinks occurring in succession. This is eye flutter, and this is another manifestation of vertical eye blink artifact. Here you see the opposite, where the waveform has a negative deflection and goes up. This occurs when you look downwards because the negative portion of the retina is closer to the electrodes than the positive cornea, which is looking downward. This causes the waveform to deflect upwards using the previously established conventions we discussed in Lecture 1. Here is another example where we have many rapid eye movements or eyelid flutter. Notice down below there are some eyelid electrodes. We haven't gotten into eyelid electrodes, but some labs use electrodes which are placed above and below the eyes. This will allow you to see if there is vertical eye blink, that there is an out of phase recording down here in the eyelids. This can be very useful to help distinguish eye movement artifact or ocular artifact from simply slow waves in the anterior region. Horizontal eye movement uses the same dipole but creates a different electrographic appearance due to the location of the dipole. The positive cornea, if you look to the left, as in this example, will be more positive near the electrode F7. However, the negative retina on the opposing side in the right eye will be more negative in F8. This creates a situation where you have a positive polarity in the direction in which you look with horizontal eye movement, with an opposite negative polarity on the other side. Keep this in mind. This is a favorite question for electroencephalographers to ask their students. And the best thing to do is to understand why, when you look to a certain direction, you'll have a positive polarity charge generated in that location. Here's an example of that phenomenon. If you look here where the cursor is, you'll see that in the left F7 electrodes, there is a positive polarity discharge, whereas in the right F8 region, there is a negative polarity. This is because the patient is looking to the left. Again, on this slide, you see various waveforms which represent ocular artifact. Where do you see horizontal eye movements? Well, if you look where the cursor is, here you see, again, a positive polarity waveform maximal at F7 and an opposite negative polarity waveform at F8. Again, this patient is looking towards the left. Remember back to where you can put a plus sign in between a positive polarity waveform, and what we see here is that the positively charged cornea is being placed at F7, which makes this a positive polarity waveform, whereas the negatively charged retina is placed at F8, making this a negative polarity waveform. At this point in the lecture, we should go ahead and review the different frequencies which are labeled with Greek letters for EEG waveforms. Less than 4 Hz, again, is a delta wave. So now we'll discuss the posterior dominant rhythm. When you begin to analyze an EEG recording, this is one of the most important features to identify in your analysis. The posterior dominant rhythm is a typically alpha range rhythm in a normal adult and is seen in the parieto-occipital electrodes in the awake state and is accentuated by eye closure, meaning you'll see a higher amplitude posterior dominant rhythm with eye closure. There is an anterior to posterior gradient, which means the amplitude and frequency are greater in the posterior electrodes. Furthermore, the amplitude is usually greater than 20 microvolts. Note that in a minority of patients, you may not see a posterior dominant rhythm or an alpha rhythm. This can be a normal variant. About 10% of adult patients may not demonstrate an alpha rhythm that's easily identifiable. This was shown in studies by Gibbs and Adams. You can identify eye blink artifact to confirm a patient is awake as well. Note that sometimes people use the term alpha rhythm interchangeably with posterior dominant rhythm. Here we see an example where the patient closes their eyes. You see vertical eye blink artifact. The positive end is maximal at FP, causing a downward deflection. And this is followed by the generation of an alpha frequency rhythm, which is seen with the highest amplitude in the posterior or occipital region. This is a typical posterior dominant rhythm. Here we see another example of an alpha rhythm. Notice the sinusoidal appearance to this alpha rhythm. And again, notice how it's seen in the posterior regions most predominantly. The posterior dominant rhythm has a property called reactivity. And this is due to the fact that when you open your eyes, the alpha rhythm will attenuate. And as we discussed earlier, it will increase in amplitude when the eyes are closed. The alpha rhythm becomes most pronounced when the visual cortex is in a resting state. The posterior dominant rhythm must exhibit reactivity for you to be sure it actually represents a posterior dominant rhythm. Here's a great example of reactivity. You see here a patient has opened their eyes or looked downward, and you really don't see a posterior dominant rhythm. Whereas here, there's very accentuated eye closure artifact, and immediately there's the emergence of a posterior dominant rhythm. This is a great example of reactivity. Here's another example of a reactive alpha rhythm. You see here the patient opens their eyes with downward eye movement, and the alpha rhythm attenuates or more or less disappears in this example, followed by eye closure, at which time you see the alpha rhythm reemerge. This is common with reactivity of the alpha rhythm. Here's one last example of reactivity. What's different about this one? Well, in this one, the patient initially has their eyes closed and you see an alpha rhythm. Then they open their eyes and it attenuates. And at this point, the patient's kind of looking around, whatnot, and it's attenuated. That's why it's important to have your EEG technologist ensure the patient closes their eyes for a section of the record. It's hard sometimes to establish reactivity without this. While we've discussed ocular or eye blink artifact and horizontal eye movement artifact, it's also worth talking about the dipole of the tongue. The dipole of the tongue is the reverse of the eye. Apologies for this clown tongue, but it's the best I could find in the 3D models in Microsoft Word, but I think it gets the point across nonetheless. The tip of the tongue is more negatively charged than the base. Movements of the tongue create glossokinetic artifact. Tongue movement towards the electrodes makes the frontal leads more negative compared to the posterior leads. This causes an upward deflection. Recall the previous convention we discussed, where if the front electrode or the first electrode is more negative than the second, that will cause an upward deflection. However, remember that's called a negative deflection, and you can remember that because the first electrode is more negative. You name it based on the first electrode, and it goes in the direction of the second. When you talk, this can lead to a fluctuating delta wave which appears and can imitate abnormalities. Here, we have an example of glossokinetic artifact. You see this here, we have these upward deflections. Well, it's just like what we discussed. This is the tip of the tongue going up towards FP1 and FP2. However, it's also helpful if your technologist will create a recording with the patient saying la, la, la at the early juncture of the record. That's what's going on here. It's well labeled that this is what's going on with the patient. This is very helpful later on to identify glossokinetic artifact. Here again is another example of glossokinetic artifact. Here we see that there are high amplitude waveforms seen maximally in the anterior electrodes. However, also notice that there's a diffuse field. This is important. The tongue has a deeper generator of the dipole than the eyes, as if you think about it, the eyes are very close to the frontal electrodes. Given that the tongue is a deeper generator, you will see a bit more of a diffuse field. This is a bit more challenging of a glossokinetic artifact. Gratefully, the technologist labeled that the patient was talking here. However, you may see that there are these slower waveforms intermixed with a normal alpha rhythm background here. This is due to the patient talking. Myogenic artifact is another important artifact commonly seen during wakefulness. The firing of motor units will create a high-frequency activity which looks like lines that can almost appear if they are touching, or waveforms that are touching. Usually, this artifact is absent in the vertex region. Myogenic artifact can be attenuated by relaxing, drowsiness, or sleep, so it can be helpful to identify a reduction in myogenic artifact, signifying perhaps the patient is not as alert anymore. This is what myogenic artifact tends to look like. If you look where the cursor is, you'll see this sort of dark confluent lines here. This is very common in myogenic artifact. Notice again how you see these lines in the temporal region and in the parietal region on the left and somewhat on the right, but you really don't see it as much in the vertex region. This is common. Again here, you see the patient close their eyes and there's an alpha rhythm, but you also see this myogenic artifact here, this dark confluent region. Myogenic artifact can be an issue in the recording as well, as it can obscure the tracing. It is important for technologists to attempt to relax the patients. Here is one last example of myogenic artifact. Again, you see these spiky, kind of very fast, dark lines here. This is what you'll see with myogenic artifact. And you'll see a lot of this as you read EEGs. Another resting rhythm of the brain, similar to the alpha rhythm, is called the mu rhythm. It's called the mu rhythm because it's arch-shaped waves, sort of like the letter mu, and it occurs at about 7 to 11 hertz, typically about 1 hertz less than the alpha rhythm. It's maximal in the central and central parietal regions, and it can be bilateral or unilateral. This is the resting rhythm of the sensory motor regions, and so it's blocked actually by corresponding limb movement. So if you see the mu rhythm on the left and the patient moves their right arm, the rhythm will block. Curiously, you can also just think about the movement and the rhythm may block. Here's an example of the mu rhythm. You see this kind of archiform, maximal in the parietal region waveform here. And see how it's really unilateral? You see it very well on the left in the parietal region, but not so well on the right at all. This is characteristic of a mu rhythm. Here's another example of a mu rhythm seen here in the right central region. Notice how you really don't see a corresponding rhythm in the left. This is also a mu rhythm. Lambda waves are another normal finding in the awake EEG. They are diphasic waves that quite resemble the letter lambda associated with visual scanning. They are highest amplitude in the occipital electrodes. The waveforms are actually positive polarity, but there is an end of chain phenomenon where they appear to have a negative or upward deflection in the occipital electrodes in an AP bipolar montage. We'll discuss more of why they look like that despite being a positive polarity waveform. They're seen most commonly in childhood, but they're also seen in approximately 50% of adults if there is visual scanning captured during their EEG. This was described by Dr. Tatum, my main mentor. Here we have an example of lambda waves. Do you see these sharply contoured posterior waves? This is what a lambda wave looks like. See also the horizontal eye movement artifact, which is associated with visual scanning. Here's another example. Do you see the lambda waves? Again, this is a bit more subtle, but you see these kind of sharply contoured lambda-esque waveforms in the posterior regions. And you know the patient is awake because you see eye blink artifact. So we discussed the idea of an end of chain discharge. What does this really mean? Well, it means you're only seeing part of what's going on, essentially. You're seeing this upward part, this upward deflection. Remember, this is a negative deflection, and you're only seeing this part on the recording. However, if you were to take an imaginary electrode and put it here, the actual discharge you're recording is positive. So it would create a positive polarity waveform if you had this extra electrode at the end of the chain. However, you don't. So the only part you see is this upgoing part. So let me demonstrate what that means on an actual EEG. I mirrored this image to make this, but essentially Imagine here, you're only looking at the occipital region. You see this negative deflection here, which is the lambda wave. However, in O2, I added an imaginary electrode X. So now you have an additional electrode. So what you would see is it would look like this because it's an end of chain positive polarity discharge. So you would have these waveforms actually go in opposite directions. Photic stimulation is a common activation procedure typically utilized to elicit epileptiform discharges. We will focus on a phenomenon called photic driving during this segment of normal awake and asleep EEG. Visual stimulation with a flashing strobe light can elicit a photic driving response, which is composed of occipital positive transients, which are entrained or time locked at the same frequency or a subharmonic as the flash frequency. Subharmonic means half or a multiple of the frequency. So if you had a flash frequency of 10 hertz, it would be 5 hertz. These photic driving responses are commonly elicited in the alpha range in adults. It's considered to be normal if present or absent. In future lectures, we will cover other types of photic activation, including photomyoclonic response, photoparoxysmal response, and photoelectric responses. Here's an example of photic driving. If you see these red lines down here below, that represents when the strobe light's firing. And you see that at the same frequency above, there are these waveforms most prevalent in the occipital region. This is photic driving. Here is another example where you see there are little red lines here representing strobe light flashes, and there are corresponding frequency locked discharges here in the occipital region. Here's another example. Can you see where there's photic driving? Note here that you just sort of see a somewhat poorly formed posterior dominant rhythm. But as the photic stimulation begins at 15 hertz, you see 15 hertz corresponding time-locked discharges in the occipital regions, which then immediately cease as the photic stimulation. Hyperventilation is another common activation procedure used in the adult awake EEG. It's actually even more useful in pediatrics, but we still tend to do it. It's used to provoke epileptiform discharges or focal slowing. It involves taking regular and deep respirations at about 20 per minute for 2 to 5 minutes. This can lead to a buildup of delta or theta activity, which tends to be monomorphic in appearance or sort of look the same for each waveform. This is generated due to hypocapnia with respiratory alkalosis as you're breathing off the CO2. This leads to vasoconstriction with decreased cerebral blood flow. Of note, hypoglycemia does tend to accentuate or increase the delta power seen during hyperventilation. So if you have a patient who comes in hypoglycemic, you may get a lot of delta power on hyperventilation. Here is an example of hyperventilation-induced slowing. The patient is hyperventilating, and you see there's this buildup of this kind of monomorphic, rhythmic-looking delta activity here. This is what you'll commonly see. This is characteristic of hyperventilation-induced hypersynchrony or hyperventilation-induced slowing. You'll hear various terminologies used, but those are two of the main ones. Here's a bit more of a subtle example. Here you see it's labeled hyperventilation. And here you'll see there's some kind of slowing of theta range, delta range, power here, or waveforms here. And then when the patient stops hyperventilating, you don't see those waveforms as much anymore. So that would be a more subtle example. And you may commonly see this sort of example in adults. Children actually tend to have more accentuated hyperventilation-induced slowing or hyperventilation-induced hypersynchrony. So now let's begin to transition into describing features of sleep. In general, we will try to adhere to the American Academy of Sleep Medicine 2007 guidelines, but there may be some slight variations in how EEGers score sleep compared to sleep physicians. In general, drowsiness and N1 sleep tend to be more or less lumped together. It represents the transition from wakefulness to sleep. It's identified by slow roving or rolling eye movements, which looks sort of like the horizontal movements of the eyes we saw before, but in a much slower manner. There's an attenuation of the myogenic artifact that we discussed earlier. And also the alpha rhythm begins to slow and shift more interiorly. The background may also contain bursts of theta. As you progress into deeper stages of N1 sleep, you will see the emergence of positive occipital sharp transients of sleep or post and vertex waves. We will go into more depth about what those waveforms appear like during your review. I will note that many EEGers call N1 sleep once they see post or vertex waves, and they will simply label the recording as drowsiness if they do not see those features but do see the other features of drowsiness. Here's an example of slow roving eye movements. Note that they look sort of like the horizontal movements of the eyes we saw before, but instead they're very slow. So here again, the patient at this point is looking to the right, and that positive cornea is here maximal at f8, and the negative retina is more maximal at f7. And then you may see the opposite here, where there's a positive waveform at f7 and it's negative polarity waveform at f8. Here's another example of drowsiness. Note how you have theta frequencies which are beginning to shift with a maximal amplitude more interiorly, and you again see the slow roving eye movements we noted before. You really don't see a well-identified posterior dominant rhythm anymore. There's a bit of one here, but it's sort of drifting away as the recording progresses. You may have bursts of theta during drowsiness, and that's not necessarily abnormal. Here you see this burst of this rhythmic theta that is centrally predominant, and this is not uncommon during drowsiness. So now we come to post, or positive occipital sharp transients of sleep, which we mentioned earlier. They signify the patient is reaching a deeper stage of N1 sleep. They are again a positive polarity, sharply contoured waveform seen maximally in the occipital leads. They're actually quite similar in appearance to the lambda waves we discussed earlier. However, they are not associated with visual scanning. Some speculate they're actually due to an offline playback of visual information. They're typically bilaterally synchronous and seen in those with intact vision. Those who are blind cerebrally may not generate post. They can occur in trains at around 5 per second at times, but they're usually isolated discharges. Here are some examples of post. You see these posterior waveforms. Again, they look quite like the lambda waveforms, don't they? Well, notice you don't see any ocular eye movement artifact in this patient. You just see these waveforms, and that's because this person is asleep. Here's a bit more of a subtle example, but again, you see these posterior waveforms consistent with post. Vertex waves are one of the other defining features of stage N1 sleep. They have a negative phase reversal at the vertex or the central CZ electrodes. They tend to last about 100 milliseconds, and they can occur in trains. They become less pronounced as we age, which is common with most features of sleep. They can also be seen throughout other stages of sleep, so they can be seen in deeper sleep, as can the post, and we'll come back to that. Again, I'll mention that technically you can grade N1 sleep by just seeing the aforementioned features of drowsiness according to guidelines, but most EEGers tend to grade N1 sleep when they see vertex waves or post. This is something to keep in mind as you go forward. Here's an example of a vertex wave. Note this negative polarity waveform that is maximal at CZ. This looks quite sharp and scary, but this is very normal. And the younger the patient is, the more you'll see a sharply contoured waveform. Here's another example. Note that the montage has the CZ electrodes up top in this one, but it's maximal at CZ. And you see again, the field is around CZ in the parasagittal electrodes. Most features of sleep are maximal in the central and parasagittal region, which is why sleep physicians typically only use electrodes in these regions. Here's a bit crazier of an example of vertex waves. You see they're kind of occurring in trains here, and it looks a little scarier, but this isn't uncommon. And you will see this, you'll come across this. But note, again, you can identify them by the fact they are CZ predominant. And also they have a very much a parasagittal field, and they have a similar onset and offset. The morphology of an epileptiform discharge will typically look a little bit different, and we'll get into that later on in a separate lecture. N2 sleep is a deeper stage of non-REM sleep than N1. This stage of sleep is defined by the presence of sleep spindles and K complexes. You may continue to see post and vertex waves, which were identified in N1 sleep. They may be present as well during N2 sleep. However, once you see spindles and K complexes, you identify the region of recording as N2 sleep. Sleep spindles are 11 to 16 Hz frontocentrally predominant waveforms. They're about 1 second in duration in adults. They do become less prominent with age. They are likely generated by synchronous cortical and thalamic firing, secondary to a drop in cholinergic activation. Here we see examples of characteristic sleep spindles. You see a 14 Hz waveform here approximately that is maximal over the central and parasagittal electrodes. Again, you see some vertex waves intermixed, but this is N2 sleep because now you are seeing sleep spindles. Notice how their duration is about 1 second or less. Here's another example of sleep spindles. Do you see them? Well, here they are. Again, they're parasagittally predominant. This patient's sleep spindles have a bit more of a diffuse field extending into the temporal electrodes, and that can be seen as well, but where they're maximal is the central and parasagittal region. Here are a bit more of subtle sleep spindles. Do you see them? Well, these are going to be a bit harder for you to see, but you do see some here. This is again sleep spindles, some here. Sometimes in older patients, the sleep spindles may appear less well formed, such as this. Notice again, you see them most in the central electrodes. This is a bit different montage than the prior recordings, and here are where the central electrodes are located. K complexes are the other defining feature of N2 sleep. They are polyphasic, meaning 2 or more phases, frontally predominant discharges. They have a high amplitude interruption of the background. They can actually be induced by stimulation. So some people assume that the name K complex stands for knock complexes, since they could be generated when an examiner makes the sound of a knock. Any type of noise can provoke them. They are likely generated by the thalamus. This is supported by evidence that those with fatal familial degeneration of the thalami do not have sleep spindles displayed in their recordings. Here's an example of a characteristic K complex. You see how it's frontally predominantly, fronto-central predominant? This is common. Also, notice how it has a diphasic waveform. This is common as well, and I like to think of it as a patient kind of nodding their head back and forward. That was described to me by one of my mentors, and that stuck. But nonetheless, you see it's a diphasic slow waveform, and also you see these sleep spindles are intermixed too. So this patient is into sleep. Here's a further example of K complexes. Do you see them? Here are K complexes, again seen frontocentrally with intermixed sleep spindles. you can have intermixed spindle-like activity in K complexes. So be on the lookout for that and don't be alarmed by it. Here's a bit more of a subtle example of a K complex. You see these waveforms here. These are less well-formed, but they're K complexes. And this may be an older patient who may not have such well-formed K complexes. Slow wave sleep, or N3 sleep, is a deeper stage of non-REM sleep. In fact, the deepest. You have to have 30 seconds of sleep recording with 20% or greater polymorphic delta activity. The delta waves are diffuse, and they're usually 0.5 to 2 Hz in amplitude. This stage of sleep is thought to allow for memory consolidation and recovery of the brain. Some have suggested it's due to activation of serotonin from the Raphe nuclei. You may still see sleep spindles during this stage of sleep. This is a typical example of slow wave sleep. Notice that there are high amplitude delta waveforms throughout the record, certainly greater than 20% of the total record. There are intermixed theta frequencies and other frequencies, but the predominant frequencies that you are looking for are these high amplitude delta frequencies. Sometimes slow wave sleep can resemble K complexes that coalesce together in a continuous manner. This would be a typical example of that phenomenon. Here is another example of slow wave sleep. Note that you see sleep spindles intermixed with the slow delta wave complexes. This is typical, and you are still in stage N3 or slow wave sleep despite the presence of sleep spindles in this instance. Rapid eye movement sleep is the deepest stage of sleep. It's also called REM sleep and is the stage in which dreams occur. Electrographically, you will look to identify rapid eye movements as well as a low voltage mixed frequency EEG background, which can mimic wakefulness. However, you do not commonly see myogenic artifact during REM sleep because if you remember, patients are typically paralyzed during REM sleep with exception of their eye movements unless they have REM sleep behavior disorder. Sawtooth waves are another feature which can be used to identify REM sleep. They are 2 to 6 Hz frequency range bursts with sawtooth appearance which lasts 2 to 6 seconds. Sorry, I mean 2 to 26 seconds. Here we have a great example of REM sleep. You see these rapid eye movements here, and you really don't see any myogenic artifact, and then you have this kind of mixed frequency background. This is what REM sleep will look like. And one thing is you'll see it progress from the slow wave sleep typically, which can be helpful for you to recognize it. Another point is that if a patient rapidly enters REM sleep from drowsiness, that can be associated with narcolepsy in the correct clinical setting, but most of the time it's just patients are sleep deprived or other issues, but a formal sleep evaluation may be indicated if there's concern for narcolepsy and you see that. Here's another example of REM sleep. It's a bit more subtle. Do you see the eye movements? Here you are. Here we see features of sawtooth waves. Notice here where the box is, you have these centrally predominant sawtooth-shaped waveforms, and then down below you see you have rapid eye movements. If you see both these features together, that can be very helpful to clue you in to the fact you are seeing REM sleep. Here's another example of sawtooth waves seen during REM sleep. All right, so we've made it through the basics of normal awake and asleep EEG in adults. I hope you now feel more comfortable identifying normal EEG patterns. Let's test your knowledge with some questions. Question 1. If you close your eyes, is there a positive or negative deflection in the frontal electrodes? Which direction does the waveform go? If you answered positive deflection and downward direction, then you would be correct. Keep reviewing this as it can get confusing, and using the models which I established in lecture 1 can help you to understand rather than memorize, which can pay dividends down the line. Here's the model. Remember, if the first electrode is positive, then it will go in the direction of the second electrode or downward. And again, I think of these kind of weights in a Cartesian plane that then go slant downward, pointing downward if the second electrode is negative. Question 2. Which direction is the patient looking during the highlighted region? So we look down where the box is here. Which direction do you think this patient's looking, left or right? If you said left, you would be correct. Question 3. When is the alpha rhythm most pronounced? With eyes open, during eye closure, or with mental concentration? If you said during eye closure, you'd be correct. Remember that the alpha rhythm attenuates with eye opening and is accentuated by eye closure. Mental concentration may also attenuate the rhythm somewhat. Here is an example of an alpha rhythm, which is accentuated by eye closure with vertical eye blink artifact. Question 4. Which type of waveform are highlighted below? Post, vertex waves, or lambda waves? If you answered lambda waves, you'd be correct. Notice that there is myogenic artifact in the recording here, and you do see vertical eye blink artifact and horizontal ocular artifact, so you know the patient's awake. And remember that vertex waves and posts occur during N1 sleep, whereas lambda waves occur during wakefulness during visual scanning. Question 5. Is this patient awake or asleep? I'll give you a few seconds here. If you answered awake, you would be correct. Remember that when you see vertical eye blink artifact, as well as a posterior dominant rhythm, then the patient is awake. Question 6. What stage of sleep does the EEG below indicate? You want to look for identifying features of certain stages of sleep. What do you see? If you answered N2 sleep, you would be correct. N2 sleep is identified by K complexes as well as sleep spindles. Question 7. What stage of sleep is this patient in? Remember again to look for identifying features of different sleep stages. If you answered REM sleep, you'd be correct. Notice that the patient has horizontal ocular eye movements and you don't see any myogenic artifact or other features of wakefulness. Here is a list of the references I utilized for this lecture. You'll see a lot of similar titles from the first lecture with some additional research articles here. All right, you've done it. You made it through normal, awake, and asleep EEG. Hopefully now you have some understanding of the normal features of awake and asleep EEG. Ultimately though, you must read thousands of EEGs to know what constitutes a normal EEG. The more normal EEGs you interpret, the more you will begin to understand the physiologic limits of normal brain activity as recorded by EEG. Next episode's exciting because we'll get on to normal variance of unknown significance as well as artifact. These are the two biggest confounders that novice readers may mistake for abnormalities. We'll go in depth and make sure you don't make those mistakes. Until next time.